Hi. You talk about iron in the brain being detrimental. What about other heavy metals like mercury, cadmium, in paint, zinc, aluminum?
You're going to wish you hadn't asked a heavy metal question. 14 years ago, I'd had MS for a year. I looked at chelation, and I had hair testing done, which is a valid test, and even House talks about intravenous chelation for heavy metal poisoning. The heavy metals are mercury, lead, cadmium. Cadmium's a really big deal. It's a really big deal in BC and Alberta. Why? Because when they do a clear cut, the cadmium's been stored in those trees for 20 and 50 and 100 years. The ones that are left to rot in the ground release cadmium dramatically into the watershed for the next 10 years. And we drink it. So most people aren't even looking at cadmium. When I had my measurements done, I didn't have any cadmium, fortunately. I guess I just recently got to BC. From Saskatchewan, we don't have as many trees there. But anyway, I had a lot of lead. And I had some mercury. So I had my mercury fillings out, and I think that's a worthwhile piece to do. I really do. You can get it done. It doesn't have to be done by the super expensive dentist. It can be done by your dentist as long as they're consenting adults and take reasonable care to do it. All right? But you want to be on the antioxidant regimens when you're doing it. The same with lead. So I had 10 go-rounds of intravenous chelation. Then my touch came back. Now it went away again 6 months later when I tried to go back in the operating room. That's a whole other issue. And when I had my heavy metals all tested, I was actually under the standing I could get my iron tested that same way. I went to a chelation expert in Nanaimo, and I still have a huge amount of lead and mercury. Now you don't want to start to move those suckers around casually, because you'll feel worse temporarily as you're moving them out. So you want it to be done with someone who knows what they're up to. There's good people do it here in Alberta. So the heavy metals is a piece. They didn't have Mad Hatters for nothing, okay? They were using it to soften the rabbit fur in the hats. And that's where it came from. Heavy metals will still be a piece of the puzzle. Won't be all of it, won't be all of us. But the hair testing is a recognized method. That's a place to start, reasonably inexpensive, and or a challenge test when you're on it. And my hope is when you do that piece, hopefully the iron will reduce as well, but we don't know. Iron may not be the rascal we think it is. It's still highest on the list. One area they're going to be researching this particularly well will be in Saskatoon. Why? Because they have one of the only synchrotrons in Canada. And that allows them to tell iron 2 from iron 3, you know, Fe2 and Fe3, and piece out some of these other metal issues. You know, they're trying to work hard at becoming one of the niches for research. Neuroscience is brilliant here at the University of Alberta, but they've got a roadblock in front of their face at the minute.
This is for you, Dr. Cole. I'm going to get political here. I tried Googling to know if there was clinical trials done when cardiologists went putting in stents into for heart pacing. I couldn't get an answer. Was there clinical trials for that procedure?
No, there was not.
Yes, there you go.
Okay.
Because I really feel this is discrimination.
Oh, this is huge discrimination. If we were men in our 40s and 50s with chest pain, we'd be all over it. I didn't say it casually. Cardiologists would treat us. The symptom improvement is dramatic. If I can get somebody bowel and bladder control back, get rid of their muscle spasm without drugs, I mean, this is just nonsensical. This is outrageous. It's even up to outrageous. Yeah. So, let's go back to that for a minute. Give you the details on it. We started doing coronary artery bypass grafting probably in the 60s, certainly in the 70s. All right? We did it for chest pain. It took us 30 years of study to show that it actually improved length of life. And then only in the people with triple vessel disease or left main stem disease, 2 specific coronary artery diseases. Coronary angioplasty, you know, started in the late 60s, the first one you saw on the board, but it was the same. A cardiologist made 4 of these catheters on his kitchen table, did several cases, presented it at a conference, talking about it. Within 6 months, everybody was doing it, all across North America. We didn't have any data. We're still trying today, and it's bloody confusing because I've been on to try to find the same thing. They're still debating what they should do. We moved on in coronary angioplasty. After doing it for 15 years, we decided if you need more than 2 stents, go straight to coronary artery bypass graft. That's where we progressed. We're still challenging each other. What's the right way to treat carotid endarterectomy? We've been hoodwinked here, folks, because we've been said, well, we must do it the same as we do a drug trial, double-blind, randomized controlled trial. But you can't really do a blinded controlled trial. When you wake up, feel like you've been kicked in the neck, because you've had significant stretching. This is another place Ruben got it wrong. He said, moving inside a vein is painless. Well, yeah, it might be, it isn't moving inside it because it doesn't have any fibers. But if you stretch it up to a decent amount where it might need to be 18 to 20 millimeters distance, then it hurts a considerable amount. I was also grateful because they've got someone in the operating room to give you a painkiller at the same time as medication because they've got an anesthesiologist on site. I would suggest to you some of the centers who won't budge from using from small balloons to large balloons because they want to keep it in their simple site. They don't want to bother having an anesthesiologist around because it's more hassle. It's more expensive, it's less for them. I mean, let's get down and dirty here. So I like to go somewhere where they're going to look after me. They're going to look after me, my EKG, my pulse, and they're going to look after my pain control and holding. Whether you can mimic that, I mean, the study out of Buffalo, they're going to rub you really hard on the chest before you wake up. Good luck, folks. It's not, people aren't that tough.
I have a couple of questions. The one question is the studies that are people that are going for the treatment when they're coming back, are they continuing with their disease-modifying drugs? The neurologist I see is saying that the testing isn't correct because a lot of these patients are continuing with the disease-modifying drugs, and that it's not a very fair study. The other thing is, he feels that an angioplasty would cost $2,000 here in Canada, and why are these places charging $10,000 for this treatment that he feels they're making money off the sick?
Well, does he get a paycheck? Well, sure he does. Okay, making money off the sick. Yeah, we could probably do them for less up here. All right? But we can't even do them. They won't let us do them. Put that back on them. Okay, do they stay on the disease-modifying drugs? Yeah, some of them do. I've had one fellow, he stayed on Sabri another month. And then he said, pitch this. I'd get off him, personally. You're going to spend, currently, roughly 10 grand to go and get this done. That's half your year of these drugs. All right? We're misplaced. If you save 1 year's drug therapy, you could pay for this 5 times over in Canada. I would suggest in Canada it might be $2,000 to $5,000 by the time you do the intervention or the assessment and so on. And that will improve over time. But if we get started doing clinical trials here, put this back to them, until we do clinical trials here, we won't do it here. There's no reason in the world not to be doing them now. So, other than that tiny suggestion, now the conservative people say, well, leave them on their disease-modifying drugs. But that goes to another age-old concept. Don't take somebody off a drug because if they get worse, then it's your fault. I don't like that way of medicine. I talked to a young fellow, he graduated out of McGill, he was about to start general practice in Toronto. I met him at a Canadian pain meeting, and he was about to start practice, and he didn't want to go to northern Quebec, because of course anyway, it's a whole different deal. And I said, well, you must be excited about getting some of these older people off their 8 to 12 medications. And he said, no, I'm not going to change any of them. If I take them off a medication and they get worse, it's my fault. Well, you know, get out of practicing medicine to save your butt getting sued off, that's nonsense. Most of us are on drugs way too long. There's a lot of damaging drugs out there. Some of them are creating our disease. It's going to be the next thing we're going to have to fix with MS patients because some of us are on clonazepam as an anti-muscle spasm. It's a hugely addictive Valium cousin. And it's got its own set of issues. And you can't stop it cold turkey. You'll go into withdrawal beyond belief. So, some people are tough as hell and they'll get off fine. And most of us are going to have to taper those really gradually. So, they're only looking at part of the issue. Those people are providing it, well, sure. And every Tom, Dick, and Harry now is starting it up in the United States. That's why it says it matters where you go. Do you want to go to Walmart? Well, you decide.